Hello, everybody. Is that on? Okay. I'm Jen Orthman Murphy. Thank you so much for having this session and asking us to discuss this really important time in the journey for patients and families with ALSP. Just to start, if everybody could introduce themselves, so when you answer the question, people know who you are and where your perspective is coming from. I think that'll help before we get started.
My name is Aaron Baldwin. I'm a genetic counselor at the University of Pennsylvania. I work alongside Dr. Orthman, and really excited to talk to everyone today.
I'm Erin Sullivan. My mother had ALSP, and I'm now working with Sisters Hope Foundation.
I'm Caroline Bergner. I'm from the University Hospital of Leipzig in Germany, and I've been working in the outpatient clinic for adult leukodystrophies there for 2 years now. I'm also trained as a neurologist.
Thank you all for being here. So we're going to focus in on this first visit experience, and we're going to talk about it from a few different angles and appreciate all of your perspectives. Feel free to jump in and make points, although I'll direct some of the questions specifically to you. And also, please, if anybody has questions, we will welcome them as part of the session. So the first topic that we'll discuss is thinking about the key points that you make sure to share with someone who's coming to this first visit. So the first scenario is someone who's coming in to get genetic testing for ALSP specifically. And I'll start with you, Aaron, for that. What are the key points that need to get across?
Great. And I think it's a great question. And there are so many different pieces that need to be addressed during that first visit. There are a lot of patient concerns and questions. I think one of the first things to start with is to ask patients what they're looking for. Every patient has a different story of how they got to that genetic counseling visit. And I think that's a really important thing to kind of go over from the start. In terms of, other pieces to kind of discuss during that first visit, it's important to talk about, the limitations of genetic testing, what we might find, what we might not find, and kind of explain that, there is some uncertainty with many of these conditions, even the known mutations in known genes. And so it's important to kind of be able to give that framework ahead of time so that patients have realistic expectations moving forward in the process. I think one other really important piece is to let the patient know that, you're now with the care team who is there to help you moving forward in whatever way that is, whether that's doing genetic testing that day or taking time to think about it and making sure that's your own decision. So those are some of the top ones that come off my mind.
Great. Thank you. Along those lines, for the next step, we have a positive result now. Dr. Bergner, can you share with us how the discussion goes with someone who's coming in and you've let them know that there's a positive result?
Well, I think in general, it might be a bit different how it goes in Germany than it is in the US, and maybe also for the first point. But for us in Germany, would always be very important if you have the first contact with the patient is that you always have the right not to want to know the diagnosis. And so I think whenever someone comes in for genetic testing, you need to make sure that he really understands what this will mean to know about the disease. So you have to explain the disease, you have to explain the inheritance mode, what it means to all the relatives, what it means in terms of therapy that could be available. And only if the patient knows this, and in Germany there are very strict regulations that then you need to wait for at least 24 hours before you initiate the genetic testing. It might be similar here. And I think this is important. And then I think in general, there are two kinds of visits. So we have, on the one hand, we have patients that come into the clinic that have symptoms and someone suspected that this could be ALSP. And then, of course, we have the relatives, which in most of the cases don't have any symptoms, but they come because they would like to be tested and to know if they could eventually develop symptoms. And I think for this latter part, I think the discussion will be completely different than for the former. And I always try in this disease, and this is, I think, different from other diseases, genetic diseases, where you do not really, you cannot cannot really offer the patients a lot. I think the important thing is that in this disease, we really try to encourage patients now to go for genetic testing, also the asymptomatic one, because we have seen, I think, in quite a few cases now that we can offer stem cell transplants. And we have hopefully more treatments available soon. So I think this is something that we really need to explain the patients and or the relatives, and to encourage them to go for genetic testing, because this is opening up treatment possibilities.
I think it's really important that she explained the two kind of divergent paths the conversation can take, whether they're asymptomatic or symptomatic, and the points that would be addressed at the first appointment would be significantly different. We at Sisters Hope are working on developing a protocol for asymptomatic carriers that they can take to their local neurologist, and that will help guide the discussion, how often they need to be monitored, what pieces need to be monitored, and then if they do show symptoms, next steps for that. So I think that would be, for an asymptomatic carrier, an important piece to have at that first meeting. For a symptomatic patient, one of the big things, of course, is connecting them to Sisters Hope, because we are we house all of the information, whether it's clinical trials, research, and support.
Erin, while you're talking about that, what do you think, what have you heard from the community about what people wish they had heard?
I think the biggest thing that we hear is they just need support. They feel really alone, especially if they're working with a local neurologist, somebody that doesn't see ALSP patients all the time. They don't feel heard. They don't feel understood, and they a lot of times, unfortunately, get brushed off, and that's unacceptable. So I think just really working to educate local neurologists and getting the word out that there is a patient advocacy group. There are neurologists that are specializing in this disease, and that we're working now and have been to continue to build out support that they need, not just for the here and now, which is super important. Like, we have resources to support them during the journey, but that we are working for, viable treatments and hopefully ultimately a cure.
Thank you all for this. I have another scenario for you. So we've talked about the first visit, and I think we're starting to close the gap to a first visit not being the 7th or 8th visit. But let's say it's a second opinion, or, more opinion about the diagnosis. How do you approach that visit? And that could be having a variant of uncertain significance as the finding, or just not sure.
And I think from a genetic counseling perspective, I can say that, again, like we've reiterated so far, listening to the patient's story about, why are they looking for a second opinion? What part of the diagnosis or, the genetic background is concerning, or, actually is making them come in to see another provider. And, for me, I think anything that we can do as a care team to kind of help alleviate any additional stress that might come with the uncertainty that comes with this condition is important. And so I think that, if we have a patient coming in for, if it's appointment 2, which would be amazing, right? We would, be happy to, really address whatever needs they might have at that time, whether that's, needing, social work, or needing, family intervention or planning. We can be there to help inform family members. Maybe the diagnosis has been made, but there are still additional concerns surrounding letting family members know, and maybe that's playing into the uncertainty that, is making that patient come in for a second opinion. So I think, just being willing to connect with families, being willing to connect with past providers and neurologists, and collaborating in a way that helps the patient.
So to me, it never happened that a patient came for a second opinion for the genetic result. So I think this was, in most of the cases, this was quite clear. but what we saw was that patients would come for a second opinion on whether or not they should or could be treated. And I think this is something that, to me, also is kind of still a journey of learning, that to give an answer to this question also for everyone is not easy. And it's not just easy because we have so little data, for instance, on transplantation, or we are now having an ongoing study which just a few patients where we also don't know what we in future will counsel or recommend to the patients. But I think with the transplantation, for me, it was interesting to see that sometimes it's not just that we have so few data about how many patients will survive, if this makes sense or not, but also that this depends very much on the individual setting of the patient. So what kind of remaining symptoms would be tolerable? What is something that he would or she would like to live with, or what is the perspective of the patient of what is worth to reach at the end, and this very much influences the decision on whether you should recommend the transplantation or not. And this is very individual. It's depending on, I don't know, the sociological setting, the family, maybe even religious beliefs or whatever. And I think for doctors, it's really difficult. And on the other hand, I feel that often patients are very, they become unsure, because you could go to one doctor who recommends you go for transplantation, and the next one says, okay, I wouldn't do it in your way and in your position. And I think it's important to keep in mind that given we have so little experience still, you cannot avoid that. And I think there's very much on discussing the setting and everything with the patient, and you might not just do this within one visit, but you need maybe some follow-up visit to really come to a decision for treatment or not treatment.
That leads exactly to my next question, but if you want to talk first, go for it.
I think the point was well made that they may be coming in for a second opinion on treatment options. Because going back to, how does a patient feel in the first treatment, especially if they're not in a position where they're with an expert, there's nothing that's happening to set up a care team. There's no talk of treatment there. To be frank, the local neurologists generally don't even know how to treat the symptoms adequately. And so it makes complete sense to me from a patient perspective that they would seek out a second opinion in hopes of trying to improve quality of life in any way possible.
So essentially the next step is what you've both alluded to, is like, now we've had our first visit. I've had the experience in many types of disorders, not just ALSP, where you listen to about 10% of the discussion in the visit, what happens next, right? And so, the themes that you brought up, if you get hooked up with Sisters Hope Foundation with all the materials that you've developed, you need a follow-up visit, right? To know that you can go back and ask questions, but also get connected with the centers of experts who have seen it before and are developing protocols. How do you approach next steps with someone? How do you do that, all of that? Because it's a tall order.
From the patient advocacy perspective, we just go into it knowing it's going to be an ongoing conversation with them, making sure that we continue to reach out for as many times as we need to, because we all know or have seen what's the next first steps and when do those happen. It varies from person to person. When are they ready to accept the results and move forward? So at least in our experience, it's just continuing to reach out and connect, and then just being there when they're ready to talk about it, to offer resources and help connect them into whatever direction they want to go. Whether it's just, we just need to do the support, maybe we want to talk to this expert, maybe we want to look at a clinical trial, natural history study.
Yeah, I think the answer again is very much dependent on which kind of patient, which state, and so on. But what we were talking about before also is that I think something very special about this disease is that sometimes it goes so quick that you will not have many follow-up visits on your side, and how you deal with this probably is also different in Germany and US and so on. But we started to do remote visits and to video visits with relatives in the beginning, very frequent, like every 3 months, shortly, but just to follow up and stay in contact. And I have to say, we learn a lot from them at this stage, because before we just did not see, okay, what are the major issues, what are the main symptoms that evolve in this late stage when patients don't come to the clinic anymore. And then, of course, we try to implement some home care services. But in Germany, we have more palliative care. We have social workers that we could involve. And I think this is really important at this stage. If there is no treatment available, or if the patient doesn't come to the hospital anymore.
Mm-hmm.
I think you guys both made really great points about follow-up procedures and next steps for these patients. And I think it's also important, like was mentioned, that, every patient sees this differently. It's a different diagnosis for every family and every patient. And I think part of that is just allowing time for, digestion of the condition, understanding, the background, and taking time to really think about what that means to that person moving forward. And I think that's a critical piece of care, which speaks again to the importance of, following up over time, and maybe meeting via telehealth, where it's a little easier for a patient to get online at home versus come all the way into the clinic, when there might be physical manifestations that are already making that difficult with the high disease burden. So I think that's really important. And, one thing I like to mention is that, when we see patients in clinic, it's really a snapshot of what's going on in their life. And this follow-up care over time can really kind of open the landscape in a way that you can truly understand what are the financial implications, what are the family-based implications, what other, pieces are concerning for that patient and that family. And I think that's, one of the most important things outside of, letting family members know and, giving avenues for patients to feel comfortable sharing their genetic results with family members and maybe even friends.
And I'll add onto that, I think we're all kind of saying the same thing. So to be just very clear, this is the big next step is really building out their care team. And that includes a variety of different people, all working to support the patients at various stages of the journey. And like maybe, like you talked about, it's hard for them to get into the neurologist regularly, but they still have ailments that need to be monitored. So a primary care physician may be the better choice to follow up on that, where they're telehealth. And I appreciated what you said about having even a genetic counselor continuing to be on that team as they're working through the family implications of this. And so again, at Sisters Hope and working with the doctors and our medical and scientific advisory counselor, we're working on recommendations for how to build out a care team and who should be included on that.
And it sounds like we've mentioned many members of the care team so far. Yes. Anybody else that we want to add? I think we've had, I think you have your if you're far away from a center of expertise, you have your primary care doctor, maybe a local neurologist, and then access to your expert potentially, and their social worker, maybe in-home nursing and physical therapy and occupational therapy and symptomatic management, urology, all of the experts that can kind of help make someone feel better over the long term. But that may not actually be what you need at your first visit, right? And the understanding of what will be needed just will depend on where you're coming into it. I think that has been the theme several times. One of the questions that we raised when we were coming up with questions is, how do people respond to this diagnosis? We've had a range of responses to it, and I think that I'll just let you comment on it, but I think that guides your next steps after your first discussion.
And I can start here. And, like Jen mentioned, that piece from the patient after giving a diagnosis, their reaction is really important, I think, for next steps, especially that day. We've had patients where we've diagnosed in person in clinic, and there's been shock and disbelief. Sometimes there's this desire to not fully grasp the results, and maybe in somewhere in the back of your head think this isn't real, this isn't really what's going on. And I think that's really important to notice. So while we're meeting with patients for a diagnosis, it's really important to check in with them. What does this mean to you? How do you feel right now? And sometimes that day is not the best day to go through all of the information that has to do with ALSP. It's a complex condition. There are familial implications, like we've discussed. There are a wide constellation of clinical symptoms. And sometimes it's just too much to give a patient that one day. It's important to give them time to sometimes digest and come back and answer questions when they're really prepared, maybe after discussing with their partner or their husband or their wife. So I think it's really important just to think about that piece when it comes to different reactions. We have some patients that, even getting a negative result through genetic testing can be upsetting. Going through this journey of genetic testing and meeting with multiple neurologists can be difficult on both ends of the spectrum. So I think it's really important to keep an open mind in how patients react to these different results. But we've seen quite a variety.
Yeah, I would just reiterate, we see so many reactions because there are so many variables. Again, whether it's a negative genetic test, a positive genetic test with no symptoms, a positive genetic test with symptoms early on, a positive genetic test with late stage symptoms. I mean, all the reactions they can just be all over the place, ranging from despair and in some cases relief, because they've been on such a journey to get an accurate diagnosis that they've, in many cases, have seen run through their family without a very clear understanding of what was happening.
Yeah, I think I completely agree to what has been said. And I think maybe I think the difficulty, most difficult part is if you have relatives that have just or experienced the disease by their parents or anything, and just gone through all the caretaking of their parents and so on, and now there's this clear picture of it will be exactly the same for me in future. And I think as a neurologist or as the one who's giving the diagnosis, there's always a balance between being open and transmitting all the information and also not hiding anything or trying to not being honest on what this means. And I think this is important to really transport the relevant information and to make clear what the significance of the diagnosis is. But then I also think there's still a range of things that patients can influence. Like, we don't know the disease well enough to really predict how the disease will be in this relatives that just is being diagnosed. And I think this is important to point out to the patient, that I believe also it really makes a difference how you see this diagnosis and how you deal with it. And if you are able to somehow develop a positive or as positive as possible attitude towards it, and to try to remain at least a little bit optimistic about what it will mean for you in personal. And I think this is kind of what we can do, or even though it's not much, but this we can try to transmit also during this visit.
I think you bring up a good point to discuss for the people that have a pathogenic variant, but no symptoms. What is the follow-up plan in this case? It's much more straightforward for somebody who's symptomatic, because you need to come back, you need to address symptoms, as well as talk about treatment. But what about in the case where there's really no symptoms?
Yeah, I think we don't know yet well what is the best strategy. In Leipzig, what we do is to see them on a yearly basis. We kind of do this in other diseases which adult onset leukodystrophies like ALD, where we do the same. And I think we will follow on with this to do an MRI, to do a cognitive screening and a neurological examination. And I think in the years to come, we will learn if this is the right way or if we should somehow alter. But I would not go for less than a year for monitoring.
Erin, I think you've been developing some protocols on this, actually.
And so basically everything that you just recommended is what we're building into our protocol, which is an annual visit with a neurological exam, an MRI, a blood test specifically for liver panel, and then a baseline neuropsych eval, and then just yearly a very simple, the MoCA test, I think is what we have on there.
That seems reasonable. Did you want to? Along the lines of the materials that you're making, I want you to share this this wonderful resource that you have in your lap there.
So we've had this, and we're building it. We're continuing to build it out. It's our newly diagnosed kit, and this is built with the. Oh, they're following me. He's following me. Okay. We're building a newly diagnosed kit, continuing to build it out. And it's made with the caregiver specifically in mind. And so we start off with just very generic information about what ALSP is. And then we go through emergency file information, medical information, home safety security checklist. We have like a caregiver support. I don't know if anyone can see it. Excuse me. But it'll help the caregiver request the help that they need. And then we have, we're building out challenging symptoms, tips, and tricks. So we have a variety of different symptoms that may come up within the course of the disease, what it looks like, what causes it, and then how to manage it. So we have anger and aggression, apathy, disinhibited behavior, freezing gait, incontinence, and we'll continue to build those out. We also have a section on grief, a section on current clinical trials, and then for later stages, just questionnaires that they can use when they're determining in-home care or long-term care facilities.
And some of those materials will be available for giving out at the first visit, right? So
yes. And so we will have components of these online. Clinicians can absolutely request what of these materials they want in office to be handed out. And then, of course, when a patient contacts Sisters Hope, we will send them one. And this also brings up another topic that we have discussed about the potential of starting a patient advocate being available, whether in person or on Zoom, to meet with the patient either on the first or second clinical visit.
Okay. All right. So I think that we've actually addressed most of the main points of the variety of ways that someone can show up for a first visit, either with or without the diagnosis quite yet, what to do when you have it, who your team is, the connections you need to make, and the support that you may not get at the first visit, but over time. Is there anything else that you want to say as a last comment that we didn't get to before we take any questions?
I just think maybe also from a doctor's perspective, maybe we don't always know what is the best way to deal with certain situations. Like I think transmitting or transferring the diagnosis is never so easy, and it's very personal, and we always feel we kind of failed in doing it in a good way. And you have special situations, like sometimes you have 3 siblings and 2 might be affected, 1 might not be affected by the gene and so on. How do you best deal with this situation and so on? And just think it's I mean, through Sisters Hope, to get feedback from patients to see what could be done better. I think also from our side, this is really helpful to improve how to do this and also how to do the follow-ups.
Appreciate the point of the improvement. I think you also said before that, you know, a lot of things have changed even within the past few years, and we're learning as we go without having all the data available to answer the questions about the uncertainty of progression, when symptoms might come up or not. within different family members, and it's the getting the feedback is and the collecting the information over time is really the only way that we're going to be able to answer those questions. There is also this balance, I think, of having information available versus overwhelming, because it is in every way, I think we've mentioned already, overwhelming. And so I think that is something that we need to work on over time, either at the first visit or follow-up visits.
Well, and on that point, and we've all kind of touched on it, right? But it seems to be the common consensus. We're all saying, that first visit, bare minimum, let them digest the reality of the diagnosis and just put on the books like we will be seeing you again in X amount of time, 2 weeks, a month, 2 months, just to give them time to digest the reality of that and all the implications. And then in the next visit, and I appreciated this, give them time to redo their own research, right? Connect with Sisters Hope, understand the disease better. And then when the follow-up happens, they can hopefully better engage and better intake further information.
And I'll just add another point that's been echoed many times today, but I just want to say that it's so important to listen to these community foundations like Sisters Hope, the ALSP community in general. As time moves on, this is a progressive, this is a process. It's not going to happen overnight. There's multiple, avenues of change for clinical trials in terms of the way that we treat patients and get patients tested and in the door for genetic testing in the first place. And we have to keep in mind that, like was mentioned earlier, we don't know everything. We're still learning so much more when it comes to this condition. And these patient groups and groups like Sisters Hope are keys to clinicians and the medical world getting up to date with these kind of conditions. So, keep your ears open and be open to, any feedback that comes from those groups and those patients.
Okay, are there any questions either on, yes, please.
I can try to provide some feedback, slightly disagreeable, to be honest. Listening to you guys talk about first visit seems out of context because I don't see anybody getting to an ALSP diagnosis on a quote-unquote first visit unless their family has already gone through it and they're doing the, sibling or related family member genetic testing. So most likely they've either gone through a lot of other false positive tests or false negative, negative tests. And so they're finally reaching what they think or hope probably is a final diagnosis. But just consider that this has been a process getting there. I don't know. Just my quick thoughts.
I think that's an excellent point. It's like the different scenarios of how someone can end up with you to have in your office or with Sisters Hope Foundation to have the diagnosis. I think it's not a straightforward journey, and like Aaron said, you have to first start out with where are you coming from and what your expectations are to even know. Hopefully with genetic testing available, the odyssey will be shorter, but we have some work to do.
And I guess the question is it genetic testing first, or is it CAT scan, MRI, or what other tests have they gone through?
Yeah, I think if anybody wants to take kind of comment at that, I think that's, I think you need the genetic test to know that we have a CSF1R pathogenic variant to be confident in the diagnosis, but I think that's not going to be the case for everyone, even if you symptomatically fit. And I think we all know of a few examples of that.
I'll just say to that, again, what's been echoed is, and exactly to your point, it's a very complicated journey.
Yeah.
And even with a family history, it can still be a complicated journey. So what's first? It depends on the person. It depends on the background. And we're still learning, right? Like we're still figuring that piece out.
Yeah. And we need diagnostic criteria.
Yeah, but maybe also your point is important that I mean, in Germany, it's different in that we do not have any problems with doing genetic testings because normally this is kind of covered by the insurance if you decide to do it at least in part. And I think what is really a shame, but also in other leukodystrophies, is that you have such a long odyssey until you end up with a final diagnosis. And then usually for this patient, it is too late to go to any treatment, and only maybe relatives can benefit from this knowledge then in the family. And I think what is important is that this is not just about having the genetic test available, but also about educating physicians. And maybe, I mean, that in other diseases, there are like leaflets where they just show pictures of how it looks like, when should you think of the disease. And I think all this is very important. And maybe also in general to make physicians more think about rare diseases, because maybe former times you could say, okay, none of them is treatable, but this is not true anymore. And you really need to at least the one that you could do something, you need to think of them and to know them, I think.
Can you expand a bit more on where the education needs to go?
I'm not sure what's like in America. I think in Germany, I think we would try to bring this more to the general neurologists mainly. I mean, I have worked it's a hospital in Göttingen for 10 years, and I saw in total 2 leukodystrophy patients, and the one was diagnosed after 9 years, and the other was something similar. So even in the university hospital, and there are a few places where you really see a lot of these rare cases, and I think you have to organize the system in a way that you, if not yourself are coming up with a diagnosis, you know where to refer the patient to, and just to think of this as something that could be time sensitive and not something which is just academic and without any consequence.
I think I'll just kind of support that. I think educating adult neurologists, because this can be misdiagnosed as many other disorders, where we actually end up seeing a lot of the testing done already by the time they come in with a genetic diagnosis. So it's already been done, but although it may not be as clear for the asymptomatic people that have the pathogenic mutation. So I think we would favor collecting the information in that case. But again, we need our consensus from our experts to sort of have that information out there as the right thing to do. Any other questions? Okay. All right. Well, thank you all so much. I appreciate your time and your expertise, and we can move on to the next talks.
Good afternoon. Oh, I need to page up. Yep, I'll get there eventually. You can tell that's not my strong suit. Good afternoon, everybody. It is a real pleasure to be here. And before I get started, I just want to say on behalf of all of us at Vigil Neuroscience, we're really thrilled to be invited to be part of this session. Thank you so much, Heidi. We're beyond grateful to Sisters Hope Foundation as well as ULF for partnering with us, but also for the incredible work to date in what we all know is a very challenging disease. I've heard that this has been an excellent meeting so far, and I'm really honored to be here today to help wrap it up and to spend some time with you and share the progress we've made at Vigil. I believe last time we shared information with you was in January at our ALSP community webinar. And I'm really excited to say that there's been a lot of work that's been done since then. So maybe before, I'm going the wrong way again. I'll get there eventually. So just to remind you about who we are, as we have discussed before, we're a clinical stage therapeutics company. And what that means is that we have very exciting research in progress with our investigative medicine, Vigil 101, which is currently being tested in humans. In our research, we're working to develop treatments for both rare and common neurodegenerative diseases. Our research is focused on cells in the body known as microglia that play an important role in the immune system in the brain. Microglia support the health and well-being of the brain, and they regulate a number of neurological functions to help prevent neurodegeneration. When microglia are not working well, this is referred to as microgliopathy, and it is known to be a root cause of the disease process in ALSP. Our investigational medicine, Vigil 101, is also known as precision therapy because it's been specifically designed to target microglia. By targeting these cells, our goal is to slow down or arrest the course of neurodegeneration that's associated with ALSP. And Dr. Andreas Myers, who's here with us today, will be sharing more information on our progress to date. So what's happening at Vigil is that we currently have 3 research studies ongoing around ALSP. The first study was conducted in healthy volunteers. This is our phase 1 study. I'm very excited to share that we have completed dosing in that study. And so far, we've seen excellent safety and tolerability profile with the drug. So what we're doing here is we're testing in healthy volunteers. This is not in patients. And these are really the true heroes because they allow us to then move into patients. They allow us to see that the drug is safe before we take it into a patient population. The other study that's critically important, and you heard a little bit talk about it already, is the natural history study. We also have a natural history study ongoing called Illuminate. That study is recruiting very well. We actually have increased the number of patients up to 50 because we think we can get some really, really important critical information from this study that not only is going to help us understand the progression of the disease, but will also help us in better designing the trials to ensure that we can ultimately get treatments to patients. So we're really grateful to everybody in the community that has participated in the study and continues to participate in the study. And then very importantly, we now have a phase 2 study ongoing in the patient population. So these are now patients that have the diagnosis with ALSP. This is called IGNITE, and that study is ongoing right now. We remain extremely encouraged by the support and enthusiasm that we have received from the entire LSP community, not just in participating in these studies, but also in sharing with us what is needed. How can we be helpful? How we can support the community? And one of the things that came out of those partnerships is a program called ALSP Aware, which is a program that's going to offer free, or is offering already, it's been launched in May, free genetic testing and counseling to the point we just discussed earlier on the panel, so that we can get to that diagnosis sooner and really help get the patients on the journey that they have to be on. So we're going to be sharing a lot of data with you today. I just want to remind everybody that you should all talk to your treating physicians and make sure that you're getting the right information from them. And with that, I'm going to pass it on to Dr. Myers, who's going to share the data from our studies. Thank you. And I finally got it.
Yeah, thank you, Ivana. First and foremost, also from my end, thank you very much, Heidi. Thank you to Sisters Hope. Also thank you to ULF and the organizers here for inviting us and giving us an opportunity to provide an update on where we currently are with our clinical development program. So really greatly appreciate it. Starting with ALSP. ALSP is a hereditary autosomal dominant condition caused by a mutation in the CSF1R gene, which ultimately leads to a dysfunction of the CSF1R receptor, which then, as a consequence, leads to the symptoms of ALSP. It was previously known mostly under two different terms, namely pigmentary orthochromatic leukodystrophy, or POLD, or it was known as hereditary diffuse leukoencephalopathy with spheroids, or HDLS. Now ALSP is the preferred term, since it's probably the best term encompassing like the underlying pathophysiology and neuropathology of this condition. ALSP accounts for approximately 10% of adult onset leukodystrophies. It is characterized by a rapid disease progression, and unfortunately, and that's why we're all here to date, there is no available approved therapy. For us, in order to understand the clinical picture, the clinical characteristics of ALSP, we have started by conducting a comprehensive systematic review of literature, where we reviewed and summarized findings from 90 case reports, which were based on the data of 300 individual ALSP patients. And what we find here, as you can see on the left-hand side, the table shows like some of the key initial findings and high-level outcomes. But more importantly is the panel on the right-hand side, because this clearly depicts how tricky and difficult the diagnosis of ALSP can be. So what we have seen in this data set is that only about a third of those patients were initially correctly diagnosed with ALSP, and that over 40% indeed received other diagnoses. And the key misdiagnoses here were frontotemporal dementia, MS, other types of adult onset leukodystrophies, Alzheimer's disease, and then a mix of like various other neurological conditions. And that clearly highlights the importance like of increasing the awareness and knowledge about ALSP on the one hand, so it kind of help making the right diagnosis clinically right away. But also I think it points out the importance of early genetic testing in order to increase diagnostic accuracy for these patients. In addition, we looked retrospectively at medical health records for approximately 60 ALSP patients, just to better understand like what are the main symptoms you can observe and how do those kind of change over time. And what we found in this review is that cognitive impairment was the key area of complaints, specifically executive dysfunction, word finding difficulty, confusion, and memory loss for details. But also that psychiatric symptoms are almost equally important and represented specifically with depression, agitation, and insomnia. And while those retrospective studies, I think, give you a good idea overall, like around ALSP, there's still so much more to learn and to understand. And in order to increase our knowledge and to kind of close the gaps there, we have, as Ivana mentioned, started, it's almost coming up to 2 years now ago, a natural history study, the Illuminate study. This study is an observational study, so there's no like investigational medicine which is administered. It is set up to learn more about how ALSP occurs, how it impacts, progresses over time, and how it basically changes the lives of patients living with ALSP, their families, and their caregivers. The study is conducted as a global study. We have several sites here in the United States. There's locations in Canada, Germany, Netherlands, and the UK. For potential patients who might be interested, who do not live in one of those countries, there are as well options for like support with regard to travel and housing in order to enable those interested patients to potentially take part in the clinical trial. And just looking at like what are how are those patients who enter the natural history study? So they're all at least 18 years of age or older. There needs to be an evidence for a CSF1R mutation. And then it can be patients who either have symptoms of ALSP, so a full picture of ALSP, meaning that there are 2 or more symptoms you typically would expect in ALSP, plus findings on the MRI imaging, which are also aligned with an ALSP diagnosis. Or there are also patients entering this study who do not yet have any symptoms potentially, but where there is a CSF1R positive genetic test and already, even if it's small, findings on the MRIs. So this slide just gives you a little bit of a general idea what happens during the natural history study. For participants, it will take approximately 35 months, and the study is set up in a way that there will be a visit every 6 months. At those visits, as shown here, we take basically blood tests, we do MRIs, and there is a battery, so a collection of psychometric tests, clinical exams, and other questionnaires to just get a good idea of what the status of patients and caregivers are at that specific visit. At this point, I also want to highlight that since the study is ongoing, we have already learned quite a bit from this study, which has already impacted and kind of changed how we think about clinical development in ALSP. And I certainly do not want to miss thanking all our participants, family members, everybody who's supporting this trial for kind of being a pioneer in that regard and helping closing the knowledge gaps we have in ALSP. So yeah, thank you, Sisters Hope and everybody who is kind of supporting the study again. So with this, I want to switch gears a little bit and start talking about VGI1, our investigational antibody treatment for ALSP. But first, a few words on microglia. So microglia are our key immune cells in the brain.
Sorry.
Either way is fine. Thanks. So microglia cells are our key immune cells in the brain. So basically the first line of defense. They have, as it's shown here in the picture on the left-hand side, they have quite a various number of functions. But ultimately what they do is sense and respond to damage signals. So that could be from an infection, it could be cell debris from old cells which have died, it could be other things. And what microglia then does is, once they recognize such damage signals, is coordinate a signal-specific response and coordinate downstream, involve other cells and mechanisms in order to address the problem which is there. And conversely, if microglia does not properly work and function, then what we know is that this is associated with some rare conditions, including ALSP, but also has implications for broader neurodegenerative conditions like Alzheimer's disease, for example. And so what do we know about the connection between ALSP, CSF1R, and microglia? So what we know is that ALSP is caused by a mutation in the CSF1R gene. The CSF1R gene ultimately codes for the CSF1R receptor, and because there's a mutation in the gene, the CSF1R receptor becomes dysfunctional. The CSF1R receptor is, you can imagine, basically a little sensor sitting on the outside of the microglia cell, reacting to signals and translating those then into a cascade of other processes inside of the microglia cell. And specifically the CSF1R receptor, and that is properly functioning, is very important for the health of microglia. If there's a problem, then ultimately microglia becomes unhealthy, dysfunctional, and that then in the end causes the symptoms and the problems we see in ALSP. So now, just like the CSF1R receptor, there is another key receptor on microglia cells, which is called the TREM2 receptor. this receptor has an equally important function, can activate microglia cells, and is also like very involved in kind of processing like damage signals and making sure that there's a good brain homeostasis in place. And now the question would be like, how can an antibody, which VGL101 does, it basically binds to the TREM2 receptor and activates this receptor and therefore activates microglia. So how can a treatment activating a TREM2 receptor be helpful for a condition which is caused by a problem caused by a CSF1R receptor? And so what we know is that both the CSF1R receptor and the TREM2 receptor actually process signals inside the cell in a similar way, which is called a common signaling pathway. And this is why we believe that by activating the TREM2 receptor with VGL101, our investigational antibody, we can compensate for the loss of function, for the dysfunction caused by a faulty CSF1R receptor. So, and with this like background and knowledge, the next step, as Ivana alluded to, is usually that you take your investigational therapy into a first-in-human phase 1 healthy volunteer trial, and that's exactly what we have done. The study was designed and set up to specifically look at the safety and tolerability of single infusions with VGL101 and multiple infusions over like a period of 3 months of VGL101 in these healthy participants. It is also planned to characterize the pharmacokinetics, so in a broader sense to see like how is VGL101 metabolized, and the pharmacodynamics, meaning is there a pharmacological effect? Does it change like certain biomarkers? Plus, we are looking at immunogenicity, so mainly to see is there any specific response of the immune system towards the antibody. And as Ivana pointed out, the study has just completed dosing, and so far what we have learned is that VGL101 in the study has been generally safe and was very well tolerated at the doses we studied, that the pharmacodynamic profile and the pharmacokinetic profile overall support a once monthly dosing IV infusion regimen for potential treatment. And more and most importantly, we have also seen evidence for pharmacological activity insofar as VGL101 has moved some of the key biomarkers we have been looking at, which clearly tells us that the antibody binds to the TREM2 receptor and actually activates it and solicits effects like further downstream. And so with these data, that's a very clear support to kind of move forward with VGL101 and take it into a clinical study in patients living with ALSP. And that's exactly what we have done at the end of last year when we started our phase 2 clinical trial in ALSP, which is called the IGNITE study. This study is designed to assess the safety and the potential therapeutic effect of VGL101 in ALSP. It is also conducted as a global study with several sites here in the United States and additional sites in Germany, Netherlands, and the UK. Again, similar to the natural history study, there is travel assistance available if there should be potential patients interested who do not live in one of those countries in order to make it possible for them to join the study. So just to give you a little bit better idea on the study design, which is shown here at the top of the slide. So basically the study starts for participants with a screening period of around like 4 weeks, which is then when patients enter the actual trial, followed by a 12-month treatment period. During this time, there is a monthly infusion of VGL101. And this 12-month period is then followed by a follow-up period. For the follow-up period, patients can decide if they want to continue with the investigational therapy or if they kind of want to leave the trial at that point. The readout, so when and how we will be looking at the data. So we'll be looking at the data in a first analysis after patients have completed, like all patients have completed like 6-month duration of the treatment period, and then we'll take another analysis and summary after all patients have completed the 12-month period. At this time, we are planning to report a first interim update on the first 6 patients for 6 months in the 4th quarter of this year. So just to give a little better idea of like who are these patients entering the study, again, all patients have a confirmed CSF1R gene mutation. They have clinical symptoms and MRI findings which are consistent with ALSP. And on the other hand, there shouldn't be any other neurological like disorders, conditions, which either could pose a risk for the patient or which could mimic and interfere with the symptoms of ALSP. And then lastly, this slide, this table gives you a better idea on like what we are actually measuring in our trial. This is also called outcomes. And here we firstly look to evaluate the safety and tolerability of VGL101 in patients with ALSP. So are there any adverse events? What are these adverse events? Just to evaluate this. Then secondly, to see what are potential changes in the imaging MRI scans and in biomarkers measured in the cerebrospinal fluid. And then thirdly, again, there is a large collection, a battery of different endpoints. So it's a clinical exam, it's a neuropsychiatric assessments, and it is questionnaires just around like general status and quality of life, which are being assessed. Yeah, and with this, like, if you are interested in finding out like more information about the trial, certainly I'll be happy and to answer any questions. But also we have listed here a few of our online resources where you can pull like additional information on the IGNITE, but also the Illuminate study and Vigil in general. And yeah, with this, I just want to thank you again like for your attention, and I think I'm handing it back to Heidi.
Thanks, Andreas and Ivana. Does anyone have any questions for Andreas or Ivana? Not online? Okay. And now we're going to take a 15-minute break. So we'll come back at about 3:20 and get started again.
Hello again, everybody. Thank you so much for the opportunity to talk today and to share this information, both now and in the long term at ULF. This has been a wonderful conference where I've made many important connections, not having for people that have experience in the field that I haven't met before. Okay. So I'm going to talk about my efforts, which are intended to be a collaboration with everybody, because there's a lot of really smart people out there in the world who are interested in ALSP, and we have to bring them all together, and we need the data to do that. And these are just some pictures of some of those people where on behalf of Sisters Hope Foundation participating in the 5K and the recent $1 Million Bike Ride. I don't look as cool, Cynthia does. But we made it through. We did it. These are just my disclosures. And so I'm coming at this as an adult neurologist. I started my clinic at Penn at the end of 2018, where I am part of the MS Center and the Center for Neuroinflammation and Experimental Therapeutics, where I study remyelination in the brain. But I had decided, it's going on its own, hold on. I decided during fellowship that there were adults who were being missed in their diagnosis, and there could be a genetic cause. And so I had the opportunity to start this undiagnosed white matter disorders clinic, and I get to work with Aaron Baldwin, who you already met. And over this time that we've actually, it's doing it again. We've actually been able to sequence or get genetic testing, for clinical genetic testing on about 100 patients, and diagnosed about 25% of them with a known adult onset genetic disorder. And so if you look for it, you will find it. And it turns out that one of my biggest cohorts was ALSP. So this meant I needed to learn about it. And so and we also have to figure out the other 75% of people where we haven't figured it out yet, right? So everyone who comes to see us is offered the opportunity to be a part of the Myelin Disorders Biorepository Project that you may have already heard of, but CHOP is the lead for this 2 decades-long biorepository effort with over 2,500 enrolled families. So all of the patients are offered the opportunity to be in the study, and if they decide to be in it, we take blood samples, imaging, clinical data, de-identify it, and bank it. And the goal is to get smarter over time. This is the short version, right? And this is part of a larger international effort through the Global Leukodystrophy Initiative, which is a National Institute of Health funded consortium where CHOP is the lead site. So I just happened to be next door with the lead site, right? And have been mentored by Dr. Vanderver, who's one of the leads of this. And this consortium includes parents, clinicians, and researchers. And the goal, many of the things that we've been talking about today, are to create awareness of these diseases that are rare and to get people that are diagnosed with these disorders ready to go to clinical trials so we can modify the course of disease, prevent it even better, or cure it. And to do that, we need to have the data of the natural history. So I was happy to be asked to chair this ALSP work group. ALSP was included for the first time in the research meeting for the Global Leukodystrophy Initiative back in September of this year. And we asked experts in microglia and CSF1R and clinicians who've seen ALSP from all over the world. We met a few times online, and then we met in person. For as many people that can come, you can see this is the whole consortium that met to discuss many disorders on that day. And so we got to be there for the first time. We discussed the challenges, successes, and needs to define this path to treating and curing ALSP. And there will be an upcoming publication on behalf of all the work groups with the outcomes of these discussions. And so this led to me realizing that in this context of my own clinic and learning about what happens at diagnosis and then what do you do next, that there's this path from getting a diagnosis to ultimately having a disease-modifying therapy. And so obviously the first step is getting a diagnosis. So that is a challenge we've already discussed, and that first visit is getting your foot in the door and on the path. Then you have to connect with advocacy and the research and support community. You need natural history studies to define these endpoints. That's what we're going to talk about. You need international collaborations because the disorders are rare. So you're going to have to find what happens to people from all over the world, and you have to partner with industry because, as you've heard, this launches the field forward, right? We're able to find the experts and make things happen. And then to understand the pathophysiology of these diseases, we have to figure out what's the best model to study these interventions, and is it going to be the same thing for everybody, or is this going to be individualized precision medicine? We don't quite know yet. And that will lead to disease-modifying therapy and improved quality of life. And so through these discussions, we graded ourselves. So I added on the colors here. So we're not perfect on any of these things, but we do know how to diagnose a CSF1R pathogenic variant if we can get somebody down the path to do that and get it paid for, right? We have Sisters Hope Foundation. We have an advocacy group who is working tirelessly to figure out what needs to be in place to do this. We have a growing set of natural history studies and international collaborations and industry interested. We're in a good place, okay? So we still need to make sure we have the right models to understand what is the issue at the core of this disease. but we need a disease-modifying therapy, and we're still working on improving that quality of life. So the successes that we noticed, or that I've already mentioned, are the Sisters Hope Foundation being established. This is a huge deal from an individual person perspective to the whole field, for the entire range. And we are working with industry partners to establish registries and observational studies. Who is affected? Where are they? And how are they coming to us? The scientific challenges, including the mechanistic understanding. What are the models to study? And does having a pathogenic variant always lead to disease? These are simple questions that we don't know the answer to. So we need improved awareness and access to genetic testing. We need to develop diagnostic criteria, one of the things we've already brought up. We need to agree on a name. This is a very confusing topic, right? Because there were descriptors based on autopsy that have sort of were combined together until we realized that variants in CSF1R caused at least some of them, maybe not all of them. But there's also mutations in CSF1R that are autosomal recessive that cause a slightly different disorder. Is this the same on the spectrum or not? We have to come to some consensus for that along with the diagnostic criteria. And then we need natural history studies. So where are we for disease-modifying therapy? As you've heard, there's no FDA-approved disease-modifying therapy. What is the best strategy? We don't know the answer to this yet. Bone marrow transplant is under investigation. Can we make those microglia work better? That's what you just heard about. Do we need to replace microglia because they're not there anymore? This is preclinical, and there may be other approaches that are not yet undergoing testing. So why do we need a natural history study? Because we need to define clinical endpoints. To design a clinical trial for testing, whether this treatment works or not, you need to know a bunch of pieces of information to answer the question. So first is, how many people have a pathogenic variant? How many people can you enroll in your study for what seems to be a rare disorder? How many people that have this variant are going to develop symptoms, and when will that happen? Which longitudinal features or biomarkers that you can collect change over time and can be used to measure treatment efficacy? Can they prevent new brain findings? Can they improve the ones that are already there? Can they prevent new symptoms? Can they resolve the old symptoms that are there? How long should a trial be? Should it be for 1 year, 2 years, or 5 years? How many patients need to be in the trial to demonstrate that it works or it doesn't work? What are the range of phenotypes that we should be monitoring in people with CSF1R pathogenic variants? How about within one family, all with the same variant? Or within one type of pathogenic variant that many people have in different families? What should be the inclusion criteria for future treatment trials? Age, symptoms, MRI findings, lab findings are some of the features that are traditionally used. And what are the exclusion criteria, like age, length of symptoms of progression, MRI findings, or other features like pregnancy? So a few years ago, I applied to the Global Leukodystrophy Initiative for a pilot grant to develop tools for clinical and immune cell characterization. And what that corresponds to is a natural history study for ALSP. And the goals of this are to establish an international collaborative ongoing natural history study in collaboration with the stakeholders. And I will also develop some immunophenotyping tools that I'm not going to talk too much about, but I think is one of the biomarkers that we could potentially use over time. It's meant to be an international collaboration, and the key stakeholders are the patients and their caregivers, the clinicians and scientists from around the world. It has to be both a retrospective, as you've heard, where we go back in time to see what has already been collected, and then this ongoing prospective collection of information where we can do in person and by telemedicine to make this accessible for as many people as possible, and to develop standard operating procedures for key assays. So for collecting as much data as we can on individuals, we can then figure out what different centers are doing and send the samples to those centers to perform the assays that whose results can be done in collaboration with many experts. And I'm working on this monocyte platform just from blood assay with a meat borrower. So just so you know, I'm working with Sisters Hope Foundation to have a roundtable discussion with people and caregivers affected by ALSP so that you can be directly included on what we should be collecting, what's reasonable to collect, how often, what we should not bother with, and how best to do it, how often we should follow up on, and whatever other opinions need to be in there. So let us know if you're interested. So to be part of this study, I'm doing it within the infrastructure of the Myelin Disorders Biorepository. So they already have a referral set up. I don't have to start anything from scratch. It's just my study within this network. So you can go to this referral study. So this is the page that comes up. And then you see this area over here. You can click off participate in a research study. You can click off more things if you want. And at the end, there's a part where you make general comments, and that's where you type in, I want to be in Dr. Orthman's natural history study. And then, after you fill out this form, you actually hear from the team at Myelin Disorder Biorepository to discuss your opportunities, visits if interested, or if you're going to consent for research. And at that point, you, a family member, or a physician will have the opportunity to submit your clinical data, your visits to the doctors, the MRIs, the lab tests. They will be de-identified to protect your clinical information. And this establishes a registry, basically who has it, how many people have it, and where you're from, but de-identified, and that alone will enable this retrospective going back in time collection of information into databases that are already developed by the GLIA-CTN. Anyone from all over the world can contribute to the natural history study with retrospective data and by filling out the survey. The next step is prospective, where you collect new data. So you can consider if you want to have, I'm happy to see you in Philadelphia. I know that is not accessible to everybody, but happy to see you for a research visit. We will also do telemedicine evaluations. We will apply standard scales for that visit going forward to see if we're collecting features that are similar to the disorders that it can be you just heard it could be misdiagnosed as, like MS and frontotemporal dementia. Again, motor function, disability, cognitive function. We will collect blood samples and process them and save them for future studies. And then we'll have patients and families fill out standardized patient-reported outcome measures that have already been defined by the NIH. And so I'm showing you now a slide that Anjana Sivagamurthy presented on Thursday at the scientific meeting that they've developed as their process for the Palazius-Merzbacher disease natural history study. And so this is the infrastructure where you enroll into the Myelin Disorder Biorepository. You're de-identified, the diagnosis is confirmed by the information that is submitted, and then with a unique study ID, and then we can start to collect all the case report information in a very standardized way. So the goals of this is that every person's experience is important that has ever had ALSP. And so if your family members have had it, then they can be part of it. The de-identified data will be shareable for collaboration with the international community interested in studying ALSP. This should enable collaboration with both researchers and industry for anyone who's interested in pushing this forward. This will generate additional outcome measures. We're learning about some right now with an ongoing clinical trial, but there's many features of this that we need to look at over time, depending on where people are coming from in the state when they get diagnosed. And then we will be able to expand our clinical experience and knowledge to be able to answer the questions that in clinic that we get about prognosis and treatments. What type of treatment should I try? How will this affect me? When will I develop symptoms? I don't know how to answer. We don't, as a community, know how to answer those questions yet, and we have to collect the data to be able to try to. Okay, so who's eligible? First pass, pathogenic or likely pathogenic variant 1 or 2 in CSF1R. Anyone with variants of unknown significance in CSF1R gene with clinical symptoms that may be consistent with ALSP, or you have a family member, or you're a family member of someone who is diagnosed with a CSF1R related disorder. And I just want to be clear, because I've asked this before, if you're enrolled in the Vigil study, am I automatically enrolled? I wish. No, it's a separate study. You have to do it separately. And I'm just making that point because I recognize that it is burdensome to be part of multiple studies. And so the goal of this is to be ongoing. So you should be in the study that is right for you. And I also want to mention that Dr. LaPiana at McGill has announced a Canadian registry for ALSP, so I wanted to make sure to advertise it and have people be able to contact her because they want to see how ALSP affects Canadians and to know who has it and how many. And I will be collaborating with Dr. LaPiana on how we're collecting the data and combining the data going forward so that, again, it's burdensome to be a part of many studies, so hopefully we can use this data where it's helpful for all. Okay, so you can be in the Vigil study, you can be in our study, the GLIA-CTN, I showed you how to join in. You can be in the Canadian ALSP registry if you're Canadian. That's all the contact, and it's up to you. And that's it. I just want to thank the patients and the families who really inspire this to happen, to recognize that there's a lot of work that we have to do. And there is a very enthusiastic international community that want to help. And so this is part of one of many and hopefully many future efforts to get this going. Thank you to Vigil for getting the community together to get this started, to organize the people who are the experts and to start collecting this data. And I think we can all work together to keep this ongoing. And thank you to Sisters Hope for helping to make it happen.
This is super exciting for us, and I think the community at large, to be talking about ALSP Aware, which, as Heidi just described, is a no-cost genetic testing program sponsored by Vigil Neuroscience, which will allow hopefully easier access to both genetic testing and counseling. This program was developed in response to what we heard from the community as an unmet need. It might not be the case for everybody that they've got access to a great care system where genetic testing is readily available. We found that's either because of financial burdens or just generally, I can't get an appointment, many reasons. So we took a fair amount of time and really assessed who would be the right partner to stand a program like this up for the community. So on May 8th, we launched this program. And it's available really in two different formats. One is for an individual patient or family member who has a known family history of a CSF1R mutation. And you can, through accessing ALSP Aware, you can either call and speak directly with them, or you can register through an online portal, and you can request an appointment with a genetic counselor. So it sort of works in three parts. You don't want to just go out and get a test. I don't think that's done anyway. You certainly always want to have the input of a genetic counselor to decide if this is the right thing for you. And if so, the informed DNA genetic counselors who are highly trained in neurological disease, specifically those obviously that are hereditary, they're a fantastic group, and they will conduct the counseling. And if it is decided between you and the counselor, and obviously a very important decision to include your healthcare provider, you'll go ahead and get the testing. I'll show you a little bit more about what that will look like, but it's Prevention Genetics who actually runs the lab. CLIA certified lab, also a really great partner, and have done programs like this in other rare diseases. If you decide to get tested, you'll then have a follow-up appointment with a genetic counselor that will talk about the test and all potential resources that may be out there for you, whether it's a positive or a negative outcome. So the other component of this, if it's not for an individual family member, is for if there are healthcare providers that don't have access to running a leukodystrophy panel. We have a program, whether you're somebody who is focused in leukodystrophies or somebody who's really focused, and you see a lot of patients who are potentially misdiagnosed and you need access to a panel. It's a 24 gene panel that's available. You work directly with Andreas and others in our clinical operations team and decide if this is the right option for you as a healthcare provider, and you can basically enroll and become an ALSP Aware healthcare provider or member of this program. So what would this look like for you as a patient? Or as an individual? So the counselor at the initial appointment, as I talked about, will collect a little bit around your family history. They'll talk about more specifics and sort of the technical components and the genetics of ALSP, and then review what are the benefits and limitations, have a very open discussion, and decide, is this right for you? Is this the right time for you? And if so, The prevention genetics group, the lab, will send a test to your home. It's a cheek swab, and the results will be available back to the genetic counselor within our 3 to 4 week time frame. At that point, there'll be an appointment scheduled with the genetic counselor, and you will talk about the results. So it's relatively straightforward process. It's an option. There are many other ways out there to access genetic testing, but from a Vigil standpoint, we wanted to make sure this was not a barrier for those who are seeking testing, and that this is eliminating that component of a very complex journey. And if there aren't any questions, I'm going to turn it back over to Heidi. Are there questions? Okay. Oh.
So if someone would use ALSP Aware, would they be given, and it came back that they had a positive mutation, is there a possibility that they would they be given an opportunity to join the natural history study?
The genetic counselor will provide a very broad overview of everything that's out there, and then that information really should be shared with their healthcare provider, and collectively they'll decide what's the next best step for them. And if enrolling in a natural history study and they meet the criteria, that's great, but that's not something that would be directly presented as a specific option by the counselor.
Okay, thank you.
You're welcome.
Now, a really special part of today's session is Find Your Voice. At the beginning of the year, I launched this campaign, and we talked about Find Your Voice, which is so much more than sharing your story. You all have such powerful stories, and we want you to share it, but it's about speaking up and asking the tough questions, and just coming forward and helping each other through this journey. This year on Rare Disease Day, we were asked to join Vigil at their new headquarters, and you're going to see a lot of zebra stripes because it's Show Your Stripes, Rare Disease Day, and we celebrated, and there were some families that were invited, and we went through a session about sharing our stories, and they had the opportunity to do a video. And it's going to be emotional, and it's absolutely amazing, but you're going to see a little glimpse of our community and how special we are.
Hi, I'm Heidi Edwards, president and founder of Sisters Hope Foundation. Sisters Hope Foundation is a nonprofit organization supporting those affected by ALSP, adult onset leukoencephalopathy with axonal spheroids and pigmented glia. ALSP is a dominant mutation, so a family member that is affected has a 50% chance of passing it on to their offspring. I started the Sisters Hope Foundation because my family has been affected by this mutation for over 20 years, long before we knew what was actually happening to my family. In 2012, when they discovered the gene, I knew I needed to do more. I had lost 3 of my family members. I knew that more would be affected. As soon as I was able to get tested for the mutation, I received my genetic testing, and it was negative. I knew what the future would look like if I was positive for the mutation, and I knew what that was going to do to my family, and I knew eventually I wouldn't be able to manage the finances. I wouldn't be able to work a full-time job. I wouldn't be able to drive my car. I wouldn't be able to walk up the stairs to the 2nd floor of my home. So where would I sleep? Soon after my mother passed away in 2012, her brother in 2013, I find out I do not carry this mutation. My sisters start showing symptoms. They're starting to have cognitive decline, memory issues, speech difficulties, and some walking difficulties, which looks a little different with each person. I do want them to be well connected. Now more than ever, I definitely advocate for genetic testing. It's available. We should be using that tool so that you have an accurate diagnosis early on. You can make decisions now. There's a bone marrow transplant option. There's a clinical trial going on. You can also start planning for the future. I needed to know if I carried that mutation because I needed to plan for my family. It is so exciting to hear biotech talk about research and drug development and know that people are looking at this space now. They're talking about microglia and that the CSF1R mutation is a primary microglia. And they want to move forward and help ALSP patients. I didn't expect in my lifetime that this would happen, honestly. I thought I would start this foundation and it was something I would pass on, my legacy, to the next generation, and they'd be fighting these battles. Knowing that there are companies out there pushing and moving forward, now more than ever, it's exciting. If anyone is at risk for carrying this mutation, you can visit sistershopefoundation.org. There's plenty of information on our website. We provide connections with others in the community, and we're pushing forward for a cure and a better quality of life.
I'm Gail from Maryland.
I'm Adam from Maryland. I'm Gail's son. My first experience with ALSP started back with my father, who was diagnosed with it. So at the time when we found out about it, I had zero interest in getting tested. I just wanted to live without thinking about knowing whether I had it or not. It's about 4 years ago, maybe, I kind of came to the decision that regardless of the more direct effects on me, the information in me, whether I have the gene or not, there could be information that I could provide that might help with research, that whether it, hopefully it helps my generation, but also better odds even that it'll help the next generation.
The symptoms my husband went through also were gone through by my sisters-in-law, but in a different pattern. So symptoms can come out first as dementia or first as walking difficulties. There's so many ways, which I have to believe is part of why they can't identify real well what it is.
Seeing the companies that are getting involved in this and the research that's being done into this is incredible. I feel like it's accelerating and it's getting to a point where we have a future, and I think they're going to get us there. Our expectation from the beginning with this is that this is a very rare thing, and why is anyone going to be interested in researching this or looking for any sort of treatment or cure for this? And it's been heartening. It's been just incredible to see that there are people out there that are willing to do this research and that are interested and passionate about doing this research and looking for ways to keep us alive.
For the future, I just want to see that there be answers out there. It's very hard for a parent to have to tell their child they have this kind of illness, and it's genetic, by the way. So having something that might be able to be treated is a more positive thing, and I'm looking for that. And I have hope in my heart for that. What I learned from going through this emotional situation was to enjoy every day that we have. And that just became my mantra, that things are not going to look good, things are going to be sad, things are going to be funny. You got to make fun of some of it because it comes across kind of strange sometimes. But it just really helped me to just appreciate every day that I was living through, whether this person knew who I was or not.
Janice Miller from Front Royal, Virginia.
My name is Lisa Miller from Front Royal, Virginia, and I have ALSP. I found out that I had a genetic disease in 2018 because my father had had something similar, and I had gotten some strange tests done because I was starting to walk difficultly. I said, would it happen to be what my father had? Hoping upon hope that it wasn't. From there, then it was just a process of figuring out how to live because there was nothing else.
You're sort of in a emotional turmoil. You know, you want to think that maybe that things aren't what's happening to her is the same because it was so different than what my husband had. At the same time, we were probably in denial, you know, hoping that maybe there's something else. But then he insisted that she have the testing done. And when that test came back, he told her, he said, there's nothing that can be done, nothing. And this was in December of 2018. It took her until October of the following year before her sister contacted Dr. Zolik and said, please, it's getting worse. Would you please help us in any kind of way? I think the word needs to get out. Somebody needs to somehow to let doctors know, to not have them understand this is important, that they can have an influence on somebody living and dying.
Any attention that's being focused, any energy that's putting toward the research regarding ALSP will help so many other people that maybe this is a little shorter of a run for them.
I'm just so amazed that there is somebody that's interested in ALSP. It's just breathtaking to think about that somebody has focused on this, and these scientists, and they're doing the research, and that they're willing to do something for people that are suffering.
I think it's no longer as something to be as terrified of as I think that I was when I found out, because the only thing I had was the end of it. And then be able to then suddenly go, hey, if you get your gene tested and you find out you have the CSF1R, that's okay, because there's something.
That's going to be exciting
Yeah.
for people.
Hi, I am Marla Chapleau. I come from a small town of Kincardine, Ontario, which is in Canada. It's 6,000 people, and this is my husband, Ron. We have been married for 28 years.
We are caregivers. Aiden was diagnosed just past the age of 2. Like all of the leukodystrophies, is slowly degenerative. I am now the president of the United Leukodystrophy Foundation, which is the original leukodystrophy organization that is now supporting incredible smaller patient advocacy groups like Sisters Hope, ALD Connect, Yaya Foundation, hoping to enact initiatives that help all the leukodystrophies sort of drive things forward.
Raising awareness is so important because if people aren't aware of rare diseases, how do they know about it to even help get further in research if it's not known?
I also think raising awareness is important because maybe it inspires some people to give to organizations like Sisters Hope or the United Leukodystrophy Foundation or the Yaya Foundation. And those foundations they do so much for the newly diagnosed, right? They connect those people, those individuals who are lost with doctors who actually know the disease. They can sort of tell them an idea of what's coming down the road for them so that they can life plan, they can prepare siblings, they can make decisions about home renovations. They provide vetted, safe information so they're not reading stuff off the internet that may or may not be accurate.
I guess as caregivers, what I would like to try to get out as a message is don't let the caregivers get burnt out. I would say let your guard down and allow people to come into your home, because once it was our family doctor that enforced it on us, seeing maybe the day-to-day grind that taking care of a special needs child has on a family. She enforced it on us. It was like an hour and a half a day to get Aiden out of bed, bathed, fed and do some physio program. And it doesn't sound like a lot, but an hour and a half you could go do an errand, get groceries, go for a walk on the beach and just do some relaxing, go and exercise, and just do some good old R&R for yourself. It makes you a better caregiver when you can then return and you feel very refreshed.
Yeah. No, there's such a burden of responsibility, I think, for most caregivers, and guilt about accepting help. It's the first time there's like legitimate hope that in the lifetime of their spouse or their child, there might actually be something that can positively impact their life and give them some quality of life that so many of them have lost at such an early age. It's incredible. I didn't actually expect to see this in my lifetime. I thought maybe at some point in time, but you look at how rare these diseases are and go, why would any company pay attention to a couple thousand people? There's no market. Tackle heart and stroke or tackle asthma where there's, hundreds of millions. The other thing I'd like to see is what we're seeing more recently, which is the collaboration where companies are talking to patients and patients are talking to the patient advocacy groups, and they're talking to each other and they're all working towards the same goal. It's not a competition, it's one shared goal amongst all of us. And I think that collaboration is really going to speed things along and make the journey much, much less alone. I know the ULF's foundation's motto has always been, you are not alone. And frequently you feel that. You're the only one in that community. You're often the only one in that state or province that might have that diagnosis. And to see such incredible teamwork with other advocacy groups, pharmaceutical industries, doctors, researchers, it's incredible.
I'm Heidi Edwards, president and founder of Sisters Hope Foundation, a nonprofit organization supporting those affected by ALSP.
And I'm Madison Boyer. I'm Heidi's niece, and I lost my mom to ALSP in 2020.
Madison and I both lost 5 family members to this rare disease. In 2020, during a bone marrow transplant, Maddie's mom, Heather, which was my older sister at the age of 45, passed away. My twin sister, Madison's Aunt Holly, was also symptomatic at that time, and she passed away in 2021. The one moment that really stands out to me is when we were in the doctor's office and we were going to be getting your mom's actual diagnosis. We already knew it was 99.9% positive for ALSP, but they needed to confirm it with the genetic testing. And it was your mom, dad, myself, you, and your little brother. And we were talking about the future, careers, what happens knowing that your mom just received this diagnosis. So that means that you and your brother may also have the disease. And what does that look like in the future?
You don't know what to expect. It's like, either you have it or you don't, and obviously either one, your life's gonna look so different.
You were strong and powerful, and when you turned 18, you contacted me and said, I'm ready, how do I do this? I need to get tested, because you're also that strong, powerful woman.
Yeah.
And I remember when you called me and you said, you were crying, and Heidi, it's negative, I don't have it. I was like, oh, thank God. I have a partner.
So I'm actually going to school to become a nurse. I've always wanted to be a nurse because I've always been passionate about helping other people, but it wasn't until my mom got sick, and I really saw when she was going through the bone marrow transplant in Minnesota how great the nurses were to her. If I could do that for someone, that would be awesome. So we've seen that a lot of companies are more aware of ALSP and are spreading awareness, and it's been really great because I still have to worry about other people in my family that could also be affected. Even though I'm not, it'll still affect me in my life. So in the next 5 years, I hope to see a cure because I always worry about my brother.
And that's why we do this, We have, her little brother to worry about. Now Maddie and I get to work really hard to make a difference and help those that are looking at treatments and a cure. At the end of the day, a better quality of life is what those affected by ALSP really deserve.
One day I can go through this and not cry, but I'm pretty sure it's never going to happen, especially when my niece talks like that, you know. And she doesn't usually talk openly, but this was her first opportunity, and it was hard for her, but she did it. And I really do feel when you watch these stories and you listen to our families, the patients involved, like, to know us is to love us. You can't help but want to help them get through this. So as you heard throughout those stories, our mission is to support and empower our families that are impacted by ALSP. Our vision is a better quality of life and to see the first survivor of ALSP. But enough crying, enough sadness, and it's now time to start celebrating. So I wanted to talk about some of the highlights so far of 2023. But first I have to share a little sadness before we go into celebrating so I can just get the tears out of the way. Today is the 3-year anniversary from the day I founded the foundation. Thank you. Which is just ironic to be standing here in front of all of you. It would be Erin's mom's 64th birthday. And I do truly believe that there is a little party going on with our families, and they're watching down. It's the only way I can get through this, you know. They are celebrating, and they're looking at us, and they're so proud. And especially they're proud at the bright colors I'm wearing today. So 3 years ago, when we realized Heather most likely would not survive the bone marrow transplant, she was in the hospital. She had been in the ICU after the heart attack for 7 days at this point, and it didn't look good. And my brother-in-law was in Minnesota with my sister, and I was with my niece and nephew helping them get through this. And I would get up early and have some time to myself before they woke up, and then I would have to pretend everything was perfect, and I needed to hide how sad and scared I was. And I realized at that point that if Heather wasn't going to survive, Holly wouldn't survive, because Holly was farther along in the disease progression. And at that moment, I knew I would be an only child, and I was not meant to be an only child. And I wasn't supposed to be without my sisters, so it was time that I made a difference, and time that I started this foundation that I had been planning. So that morning, 3 years ago, I went onto social media and I started Sisters Hope Foundation. I had already known going into this point that I wanted to honor my sisters because they were giving up so much. Heather was leaving her young children behind, and she would be in Minnesota for at least 100 days, and she had never been away from them. And Holly would have to do the same, and she was a single mom that would leave her son at home to finish his senior year of high school to go through the bone marrow transplant. And they deserved so much. They deserved to be recognized for this selfless contribution they were making. And that morning, Sisters Hope Foundation launched on social media, and never expecting that immediately, people were searching, like errands of the world, were looking for help and resources, and there I was. 3 years ago, I thought I was just putting some information on social media, and I would do a website, and we'd do some fundraisers, you know, we'd have fun. I didn't know that 3 years would be so
so overwhelming, so fantastic. We have done so much in just this 3 years. It's been sad and it's tragic, but we have the opportunity to save our families. And I promised my sisters I would save their children. And we're here today, and that has become a reality. We need to celebrate the fact that in 2023, we have our first ALSP clinical trial. 3 years ago, that did not exist, and it wasn't fathomable to me that morning. But here we are enrolling patients in a clinical trial. We have a natural history study and a longitudinal study, and we have a no-cost sponsored genetic testing program. And we had our first regenerative medicine conference at the University of California, Irvine, this year, and it was sponsored by the California Institute for Regenerative Medicine. In a million years, I never would imagine that CIRM would know who I was or sponsor an event for our families. We have also touched families around the globe, which I was not expecting and which is so exciting for me. So in over 16 countries now, people contact us and they have family members that have been identified or they have lost, and we can support them, which is my goal. It doesn't matter where you are. We're all going through the same thing. The disease is the same no matter what country you're living in, and we're here to support all of them. We started our first Global Medical and Scientific Advisory Council. Jennifer Orthman Murphy is the chair of our council, and we were able to hire Aaron Sullivan as the program and project manager to help support Cure ALSP and our Medical and Scientific Advisory Council. We also expanded our board this year. We are always looking to expand our committees, and we're looking for volunteers to help us with our programs. We are continuing to grow our social media presence, and TikTok, my one video, has attracted patients. Let me tell you, I'm super proud of that. They're out there and they will find us somehow. So with options, a young girl who had just lost her mom, same story as my niece, found us on TikTok. And I was able to connect with her and connect her with the youth in our community. We have our Facebook support group, which is a private group for patients and families only, so they can ask those questions, those tough questions that they may not want to ask in a public space. But also with the help of Erin, she runs 2 support group meetings a month. We have one specific for patients and one for caregivers. And then she also brings in speakers to provide educational content for our community. As Erin discussed, we're rolling out the newly diagnosed kits. And as we continue on this journey, we'll continue to update it. And it seems like we have to update frequently, which is really exciting. It's a lot of work, but thank goodness we have that opportunity. And we will be, like I said, we will help anyone around the globe. So with that, I can't be everywhere. Erin can't be everywhere. We need ambassadors to help in those areas. Those that understand the country, their laws, their benefits, and they're close to the family members and they can help. So we're rolling out our Global Ambassador Program in each of those countries. We have identified some patients and their families, and they've stepped up and asked to volunteer, and we're always looking for more. You saw Maddie's story, which is really powerful, and she does want to help the community. She was only 15 years old when her mom suffered the heart attack. 2 days later, she turned 16 without her mom there to celebrate. And she wants to make that difference. And I understand what Maddie and the other youth are going through at the point where they've lost someone and they receive a negative diagnosis. I don't know what it's like to be a child losing a parent and having siblings that may be affected. And I really feel that the youth, they need each other,
And we've had a number of younger youth members step up and come to us asking questions and wanting to be part of a group. So they will be able to help each other through this journey. And then my families, they're so important. I always say we have a family and there's always a spokesperson, that one person that steps up and they're going to take charge, and it's in every family. They want to make sure that they educate and empower the rest of the family members, and they want to be involved. So there will be a family ambassador program for those that want to step up and be that person in their family and help spread the word, educate, answer questions. And this year we held ALSP Awareness Month in the month of March. When I started this journey, Holly was still alive and we were still celebrating the month of March for our birthday. This has grown bigger than what I had expected, and I don't have Holly anymore, and March is honestly a sad month for me now. And I felt like I needed to transition away from my birthday month and celebrate the entire community. So as of May of 2024, ALSP Awareness Month will be held in May. So in May of 2024, we will hold another ALSP Awareness Month. I'm not sure where we will be at that time, but we'll figure it out. And I can't ask Sunil or Andreas, because they got this wrong. But Aaron, why is it in May? It's the chromosome. 5q32. It makes sense to me. It made sense to Aaron. Andreas and Sunil, the science guys, I'm not so sure. They just looked at me like I was crazy. So, but that's what we're doing. So. And I'm pretty sure right now you're all really shocked that there is a slide that is not pink and purple. And this is a really exciting event because this isn't a campaign where I want to pull in all countries, all states in the United States and have fun. It's our first in-person 5K. It's going to be held in Raleigh, North Carolina on September 9th at Fujifilm. It will be in Research Triangle, in their parking lot, and it will go through the trails near their facility. We will do a 1-mile fun run, and we will have virtual participation also. It will be rock and roll themed with a lot of music and celebration. And from this, we will create a toolkit that we can roll out so other families in other countries or other states in the United States can take that cool toolkit and they can start something just like this. I chose red, white, and blue for the United States. So as we move this event around our country, the colors will stay the same, but with the goal that when we are in Canada, Ireland, Germany, those colors will change, and that brain guitar will be a symbol moving forward. Now, there is of course, I'm very competitive, so I will win this 5K, but I do have to start training. But Vigil has a team of 10. Sisters Hope in Pennsylvania has almost that many people planning to drive to North Carolina because we're going to have so much stuff to take. So we're going to drive, and whoever else would like to join us, Penn can create a team. Yes, thank you, Erin. So I just want to thank all of you for being here today, celebrating with us, providing us so many opportunities that we didn't think were possible just a few years ago. Thank you.